The three cases that actually drove not only local and state but federal law with regard to care at the end of life all involved people who were under the age of 30 when their sentinel event occurred. In each of the instances involving these three women, Terry Schiavo, the most recent, Nancy Krzan, and then the first case, Karen Quinlan, each of those women experienced an event that is not unlikely to occur in our culture today with some frequency, unfortunately. As many people are probably aware, Terry Schiavo suffered cardiac arrest due to electrolyte imbalances that were probably the result of a pre-existing eating disorder. Nancy Krzan, the young woman that we're familiar with prior to the time of Terry Schiavo's case, was actually coming home from work one night involved in a single car accident, found at the side of the road unresponsive, leaving her in a state in which she was dependent upon technology to keep her organs functioning. The very first case, Karen Quinlan, it was a situation in which Karen had mixed drugs and alcohol at a party and was found, again, unresponsive in a home. In each of these situations, first of all, the event was not something uncommon. Unfortunately, we hear of these things every day when we pick up a newspaper.
Some of the most difficult healthcare decisions that people face are decisions about medical treatment near the end of life. They're difficult because typically we have conflicting desires. On the one hand, we know that we can't live forever, and we want to have a peaceful and a dignified death. However, we also don't want to die prematurely if there's a good chance that we can have a meaningful recovery. So we're not sure what the best care is. We're also afraid, I think, that we may lose control of the decisions that will be made about us as we approach the end of life. So I believe that advance directives are important decisions because they enable us to retain that control over what kind of care we want and don't want as we approach the end of life.
Advanced care planning is a process. It's the opportunity to have some discussion about the kind of care you would want in the future. We all realize that we don't know what will happen. No one has a crystal ball, but it is an opportunity to share, again, with your family and your healthcare providers, what you might want or not want in certain situations. North Carolinians at present have the opportunity to complete a living will, to complete a healthcare power of attorney. They also have the opportunity to talk with their doctor or their healthcare provider about something called a portable DNR, which enables them to not be subjected to an attempt at resuscitation in any situation. It is portable. It goes with the patient wherever that patient may be. And now, as of October of 2007, we have the opportunity to also complete something called the MOST, which is Medical Orders for Scope of Treatment. Again, this needs to be completed with your healthcare provider and not in an emergency situation, but involve some discussion with that healthcare provider about what you might want or not want in certain health situations. The living will is a document that provides some opportunity for a person to indicate to healthcare providers and others who might be around that person, loved ones, family, friends, at the time of advanced disease, what they would want or not want. The living will is restricted to care provided in only certain situations, however, and those situations would be if a person had a terminal or incurable disease, if a person was in a persistent vegetative state, or if a person had advanced dementia, or some other reason that might cognitively impair them to that degree.
Imagine yourself in a situation where you have thoughts about how you would want your healthcare providers to proceed and what you would want them to do to you in a certain situation, but you are either comatose or otherwise unable to talk for various reasons or no longer have the mental capacity to participate in those discussions. What this document does is allow you to make your choices well known in advance to guide the healthcare team.
Limitations are that living wills are fairly narrow. They apply only to those 3 specific medical conditions, and they typically only give fairly general instructions about not wanting life-prolonging measures. Sometimes it may be difficult to interpret and apply those general instructions in specific situations.
The advantages of the living will are that it does provide some direction to your healthcare providers about who you are, what you would want. Granted, it's only in these 3 situations, but it does give them some story about who you are. Healthcare Power of Attorney is a document that allows you to appoint someone that you trust, that you've talked with, to make decisions for you when you are unable to make those decisions yourself. It's important for people to realize that the healthcare power of attorney only goes into effect when the patient or the individual loses that ability to make decision for themselves. The advantages of a healthcare power of attorney is it clearly tells us as healthcare providers who we should be talking to, who you've had this discussion with, who knows you best about your healthcare decisions.
One of the new exciting developments in North Carolina law is that the person who is designating a healthcare power of attorney and has also drafted a living will can designate which of those 2 instruments will trump the other. There may be times where an advance directive in the form of a living will is at variance with the opinion of a durable power of attorney. The disadvantages are that the durable power of attorney obviously has to be available and present when decisions need to be made, and for that reason it's a good idea to have more than one person designated and to kind of work and to develop a hierarchy of people who are allowed to intervene with the healthcare team.
Healthcare powers of attorney typically apply very broadly, so they would apply to any medical treatment decisions that need to be made for you when you've lost the ability to make them yourself, unless you specifically limit the authority of your healthcare agent to specific types of decisions. It's really important that you choose carefully. Choose someone that you trust, someone who knows you well, who knows your preferences, who knows your values, and it's really important to communicate with that person, not just to assume that they will automatically be able to figure out what your wishes would be, but instead have a discussion with them.
The portable DNR is a doctor's order, a physician's order, provider order. It can be signed by a nurse practitioner or a PA by North Carolina law as well. The portable DNR, the advantage of that is that the portable DNR is the only document, that and the most, are the only documents now in North Carolina that will actually prevent emergency medical services from initiating cardiopulmonary resuscitation in a situation outside of a hospital. So if a person is clear that they don't want cardiopulmonary resuscitation if their heart and lungs should fail, they need to talk to their healthcare provider about obtaining one of those forms for their home or their rest home or wherever it is they may be residing.
The portable DNR is a very powerful document in that as physicians and as a healthcare system, we are duty-bound to always err on the side of preserving life. Unfortunately, sometimes people have medical illnesses or diseases that are beyond resuscitation, and they've already made the choice that they would not want to endure or undergo CPR, cardiopulmonary resuscitation, prior to death. The only way that we can stop emergency responders from performing CPR is by having a document which really empowers them not to intervene.
Recently, we have also recognized a new kind of portable physician order for treatment near the end of life called a medical order for scope of treatment, or MOST is the acronym. And that order allows physicians and patients to communicate the decisions that they've made regarding resuscitation, but also other types of health care, including decisions about whether to hospitalize the patient or not, whether to pursue antibiotic treatment or not, and whether to pursue medically provided artificial nutrition and hydration or not. So those are major options that people in North Carolina have to help guide their treatment near the end of life.
The advantage of a MOST form, which addresses not just resuscitation status, but also addresses where you want to be cared for. You know, do you want to try and stay home if you can, for example, in the case of a hospice patient? Do you want to go back to the hospital for anything that may be indicated at that time? You can check that on the MOST form. Do you want to go back to the hospital but not, for example, receive intensive care level of treatment if it can be avoided? I think one of the advantages of the MOST form in that respect is that it really encourages some dialogue with your healthcare providers about the level of care that you want now and that would be acceptable to you.
These documents help us to guide that decision-making process, to make it more likely that the decisions that are made near the end of life are consistent with our values, our preferences, our hopes about what the last chapter of our life should be.
All of us need to take the time to adequately plan and discuss with our healthcare providers what our needs, wants, and desires are. We really want to make sure that we individualize treatments.
The documents themselves are available online by going to various websites, including an online registry that is provided by the North Carolina Secretary of State's office. Documents are available online through the North Carolina Medical Society and through Carolina Center for Hospice and End-of-Life Care. Some folks will prefer to have this done as a part of estate planning, and most attorneys would also be able to provide assistance in accessing and completing advance directives.
Anyone over the age of 18 should have this conversation with their healthcare providers. I don't think that patients should wait for their doctors to ask them about it. I don't think the doctors should wait for their patients to ask them about it. I think it should be, as I say, part of routine health maintenance. Actually, surveys have shown us that patients who are diagnosed with a life-limiting disease, overwhelming majority of them, 87 to 92% of them in surveys, say that they would want this kind of discussion with their healthcare providers. We think of the three cases that really directed not just state law, but federal law in this country with regard to care at the end of life. All of those people who were involved in those cases were under the age of 30 when their sentinel event happened. So this is not just an issue for old people or people with cancer. All of us someday are going to die. It's not an easy topic to talk about. It's not a pleasant topic to talk about. But it's just as reliable as birth, and it's going to happen to all of us. And if we want control, we need to plan for it and prepare for it. I would argue that when we have these discussions, it really enables us to know how to live better, too. I completed an advance directive because I don't want my family to be faced with this sometimes awesome and terrible decision-making at the end of my life. I don't want futile attempts made to prolong my life that may cause sometimes great suffering to me and also cause suffering to my family.
I filled out an advance directive because it was a very easy decision for me to make, because I know what I would want for end-of-life care, and I know that if my family had to do the same, it may not be so easy.
I completed a healthcare power of attorney because I want to rely on my wife to make healthcare decisions for me if I can't make them for myself. We've discussed these issues, and I trust that